And thank you for joining us today for today's webinar on the traumatised limb, long-term issues and how we can address them. Before I introduce our presenters, I'd like to run through a few housekeeping points. If you can pop any questions you may have regarding the webinar today in the chat box, what we will do is we will answer them at the end, so that would be appreciated. Thank you. Also, just a quick reminder that the CMS UK and SRR Tomorrow's World Conference has now officially launched. Exhibitor slots have completely sold out, but there are still few sponsorship opportunities available. Hayley will share the link in the chat box to the conference webpage and future events, obviously, where you can view the full programme, find details about the poster competition, and obviously explore the remaining sponsorship options. So if you have any questions specific about the conference, you can feel free to contact our team on our info@email, and Hayley will also put the email in the chat as well. So without further ado, I would like to introduce you to a couple of wonderful gentlemen with us today that are going to present. We have Professor Heidari. He is a consultant orthopaedic and trauma surgeon in London and a founding member of OS Clinic, specialising in foot and ankle conditions, trauma and complex lower limb reconstruction. He practices at the London Clinic, where he leads a comprehensive limb reconstructive service, delivering multidisciplinary care typically found in major teaching hospitals. During his NHS career, he established the foot and ankle unit, bone infection unit, and orthoplastics department at the Royal London Hospital, one of Europe's busiest trauma centres. An internationally trained surgeon, Professor Heidari has undertaken specialist fellowships in the UK, USA and Europe. He has authored over 100 peer-reviewed publications, lectures widely across the UK and Europe, and plays a leading role in advanced surgical education. He's also a member of the BOA and BLRS and is listed on the GMC Specialist Register. So he will be our first presenter today. And then following that will be Mr. Georgios Pafitanis. He is a consultant plastic and reconstructive surgeon in London, working across the Royal London Hospital, UCLH, and privately at the London Clinic. He specialises in complex microsurgical reconstruction of the lower limb, head and neck, abdominal wall and limb salvage following trauma and amputation. He has completed prestigious microsurgical fellowships in the UK and internationally and holds a PhD in reconstructive microsurgery. He's an active researcher and educator, has published over 130 scientific articles, edited and leading microsurgery texts, and received multiple international awards. He is listed on the GMC Specialist Register and is a full member of BAPRES. So welcome both of you, and I'm going to hand over straight to you, Nima.
That's really kind, Rachel. Thank you so much, and thank you for the lovely introduction. I'm going to start by sharing my screen and that. There we go. So we should be able to see my presentation. I also like to thank CMS UK for the opportunity to tell you about some of the things that we do and some of the ways that we can help patients. This is my personal email address. I'm very happy to have queries from colleagues. It's my personal philosophy is to always reduce friction, particularly when it comes to communication. When you look at problems, invariably, they are as a result of poor communication. And I suppose the only way that I can try and help mitigate that is by providing access to me, so that if you do have questions, I'm very happy to receive them, and I will try my best to answer them. So today, we're going to talk about the long-term outcomes of trauma. And what we're talking about is blunt trauma. Blunt trauma invariably is the vast majority of trauma that we see in the UK. And it's a combination of road traffic accidents, which is the majority, and also accidents in the workplace. When we look at the initial care of trauma in the UK, we really are an exemplar to the world. The major trauma system, where we have specialist hospitals, which are called major trauma centers, that look after the most injured patients, is well established. It started in 2011 and was completed by about 2013. And initial care in the UK is phenomenal. It genuinely is second to none. The issue, however, is the fact that about 30% of the individuals that have limb trauma require further surgery. This is testament to the complexity of these injuries and the problems that these poor souls have. Many develop chronic pain. Dysfunction is ubiquitous. And the thing is that these problems, they're not immediately obvious. They often emerge after these patients are out of the major trauma system. And one of the big problems is that there is no cessation in the flow of the multiply injured patients and patients requiring urgent care into major trauma centers. So then it unfortunately leaves these problems unanswered. And this is where case management really becomes critical, because many of these patients end up in your care. And by ending up in your care, you are then able to navigate the healthcare for them. And here we are trying to explain some of the things that you can do. When we are looking at definitive treatment, you hear it regularly. Your bone has healed. Please feel free to go away and do not darken my door again. That's really what we do know, however, is that just because the bone has healed, it doesn't mean that function is restored. Here is a paper, long-term analysis, 10% persistent problems at 10 years, right? They continue to have problems. And when you look at those, the issue that I'm going to keep highlighting here is actually problems of the foot. You can see if you've got foot problems, you end up with long-standing functional issues. And here is another paper at the turn of the last millennia, 1999, by Jim Waddell and colleagues from Toronto. And what they looked at is two groups of individuals. One group of individuals, polytrauma, multiple limb fractures with no foot injuries, and the other group had foot injuries. And what they found is that at 2 years down the line, the group that had the foot injuries had worse outcomes. They actually were less healthy and enjoyed life less. Now, from the soft tissue side, I will leave Mr. Pafitanis to talk about this, but just because your soft tissue reconstruction from a surgical point of view is successful, it doesn't mean, again, they're asymptomatic. And the thing that I really care about is the anatomy and the biomechanics. Just because you've restored the anatomy, it doesn't mean that the full biomechanics is restored. Now, typically late presenting issues are varied. Continued pain, bones not healed, soft tissues not robust, low-grade infection in the areas where the fractures have occurred, deformity. And in my practice, the things that I tend to deal with is non-union, malalignment and deformity, wound problems, because they're invariably associated with deeper infection, and that's where Jill and I work together. And also the intolerance of prosthetics, because the amputated residuum is not particularly well functioning. Beyond all of this, the psychological burden of these injuries is phenomenal. This is something which really is very poorly addressed in general, and it invariably is a really important factor in the loss of independence of these individuals. Now, again, these are not rare outliers. 30 to 40% of the individuals that require remedial surgery, they fall into this unfortunate group where things are not quite right. Now, the orthopedic drivers of dysfunction are generally to do with the following things. If you have subtle malalignment and this could be both rotational and angular, you abnormally load the limb. And individuals who have had normal limb alignment before, and as a result of a malunion end up with abnormality in the alignment, they really feel it. And although it may be subtle in the eyes of many, it is not subtle in the eyes of the patient. These are a group of people that end up feeling that really they're not being listened to. If you have fractures that enter joints and cause incongruence in the surface of the joint, this leads to arthritis and stiffness in the joints, particularly around the knee, particularly around the hip and the foot and ankle. They cause a great deal of imbalance because you walk in a different way, you load the limb in a different way, and it can have compensatory issues with the lower lumbar spine and other joints in the contralateral limb. The idea of a bone having healed, therefore it is not symptomatic, is something that we need to get beyond. Despite union, you can still have poor biomechanics and problems. And it is these really small mechanical errors that compound over time and result in what I describe as functional penalties for these patients. The other way that this presents itself is that you find rehabilitation plateaus. The patients get to a certain level, but then are not able to go beyond. And these are invariably because there are things that cause pain. And I go back to some of the things that I spoke about earlier. We need to diagnose where the pain is coming from. Is it because of malalignment? Is it because of a non-union? Is it a psychological burden of the events that this poor soul has befallen? And these can really, the diagnosis of pain is a really important one. And of course, structural abnormality and pathologies also can be a reason why it plateaus. As we talked about earlier, stiffness in the joints, poorly functioning limbs. The secondary reconstruction decisions. How do we think about what should be reconstructed? And as I said, there are mechanical reasons, there are biological reasons, and there may be neurological reasons, abnormalities with nerves. And again, this is something that Mr. Pafitanis will touch on, very important. We need to diagnose where the problem is coming from, because by understanding the problem, we can then attempt to predict an outcome. And in these individuals, predictability does matter because they already have a psychological burden of the injury and the subsequent surgical treatment, which is not pleasant. And the idea of having more surgical intervention, it really generates a Pavlovian response of just not wanting to engage. And this is something that is also important to recognize, that there is a natural and logical limit to limb salvage. A salvage limb can become very painful. It becomes energy consuming because of its abnormalities. And it by itself can become functionally limiting, particularly a limb that has infection, it has malunion, it has got abnormality in the nerves and so on. And it's an important conversation to have to see whether the end of the line has been reached with regards to salvage and reconstruction. Repeated surgeries, they stop the patient adapting psychologically to the loss of the real loss of the functional loss of that limb. Each time you go in for surgery, it sets you back, so it increases disability. And by having to take the time out from your normal life, that also has a burden in the particularly economically and vocationally for these individuals. So really, the idea of salvaging a limb at all costs is not the best strategy in the longer term. Now, amputation I view as a reconstructive option. It is important to think of it in that way, and it is important to discuss it in that way. And for that purpose, it has to be very well planned. On the counter side, we do treat problems with amputations. Not all amputations go to plan. You can have neuroma. There can be phantom limb pain. Because of the soft tissue issues around the socket, you may get intolerance of the sockets that are provided. The skin may break down. You get bony overgrowth. So managing these problems is also something that is quite important, because obviously once the limb is amputated and you have problems with the residuum, that really is a challenge. And how do we go about dealing with these challenges? You need friends. This is an MDT approach. Here we are. I don't know if many of you recognize this picture, but this is the picture of the lone warrior out there by himself, which is how most orthopedic surgeons like to view themselves. But that really is not true. What you need in this is you really need a team. And here we are, Lewis Hamilton, and look at the number of people he requires to make him successful. And in fact, I don't see myself as Lewis Hamilton. I see the patient as Lewis Hamilton. So for that patient to reach the goal that they are aiming for, you need orthopedics, you need plastic surgeons, sometimes you need vascular surgeons, you need pain management specialists, you need to address the psychological issues that they may have. Rehabilitation needs to be designed for them in a way which is individual. You need a prosthetist who understands the needs of these patients. And they really need to be, this is where case management comes in, because all of this needs to be coordinated. Fragmented and disparate care, unfortunately, really it fails. So from the point of view of how do I view where case management comes in when my services are required, it's very much around the fact that, look, early referral, get a surgical opinion, avoid rehab-only loops, and it is really, it's shared decision-making between the patient, possibly surgeons, or whichever healthcare professional is required for that patient, and the case manager, because they are the ones that see the patients through multiple events in their recovery cycle and recovery program. And they sometimes are the best counsel for those patients to be able to make a decision. So in summary, severe limb injury is a long-term problem. Pain and function are really, they are intertwined and they are inseparable. And just because the limb has been salvaged, it is not necessarily a successful reconstruction for the patient. And just again, this is my personal email address. Don't hesitate to get in touch with me if you feel that there are issues that you want to discuss. And I think on that note, what I will do is I will hand over to my good friend, Georgios Pafitanis. He's a plastic surgeon with a particular interest in the soft tissue reconstruction of the lower limb. And his point of view on what we do is also critical, and I value it each time I see a patient. Over to you, buddy.
Thank you, Nima. Thanks to CMS UK. So we have a complimentary lecture. So my lecture will go through similar concepts that Nima just touched on and explained very thoroughly. And I also have a part where I will show you some examples of cases, and apologies for having some clinical images or intraoperative pictures on there. is something which I think is very important for you as case managers to understand, because the type of injury and what we see on table in the first instance, it really describes the trajectory that a patient will go through and sometimes predicts it. I have no disclosures. Why is this so important? As Nima just described, so we know that high energy injury to a leg offers to patient a disability, which is not a good thing. Also, we know, and almost over the years of me being part of the East London service that Nima established back maybe 10 years ago, the complications are part of the game. It's not something that we do not expect. And we do know which complex cases will need redo surgeries and try to reduce this for those patients in a battle between trying to improve also the quality of life for their visits to the hospital. And all these has to come with decision making that doesn't really incorporate what the patient actually goes through. For example, are they in pain? Can they actually mobilize, or do they need support to do these things? And on the other aspect of that regarding the patient is how they feel about all this. This is the network. Nima already described that, and you can see on the left side the London region, and I will show you some of the data from the east side of London, where is one of these major trauma centers, the Royal London Hospital. This is the things that we normally get. And why is it so important? Because from all the fractures, about 3% it's in the lower extremity and they are open. That means all these factors that kind of predict the complications for a patient rely on just because of this entity, or because a bone is broken and is open to air. And when you look at how it happens, most times it's road traffic accidents. We all expect that. And second is the falls, people that jump from bridges, etc. When you look at specifically now lower extremity open fractures, this is the largest study that is being done over the last few years, and you can see the percentage of each one of the major complications that someone can go through. And we as surgeons know these numbers and try to minimize them. For example, if a fracture is an open ankle fracture that is been in, let's say, a dirty water, we try to clean these as best possible in the first procedure. And therefore, if we did not know this is a risk factor for someone have a long-term complication rates, maybe we would commit to this person having 5 or 6 more surgeries than if we did a proper debridement in the first instance. And you see some of the other numbers here, which almost describes the root of a very complex lower extremity injury, which may lead to an amputation or not. And in between these two, it's a lot of time that the patient goes through a process that maybe reduces his quality of life. You can see that none of these patients walks within the first 2 months, and this is just the mean. So imagine that the first 3 to 6 months, someone would not be able to walk after such an injury. And we have really been at the forefront of this. UK has guidelines now, and we do know to divert those cases directly to the people that do these more often. It does not mean that every orthopedics or plastic surgeon has a special interest in that. And due to the fact and the reasons that Nima described earlier, it's quite a difficult specialty, because those cases, you don't choose when they come to the hospital. You have to be available. You have to love it. And we use certain things like this classification, for example. And the reason I put this for you there is to understand that each one of these injuries, periosteal stripping, loss of the envelope of soft tissue around the bone, they do predict the pathway and the trajectory for a patient. And nowadays, I started to understand that these classifications being done 40 years ago, they need to be updated. And I do truly believe that a lower extremity trauma involving degloving or crushing is a different injury than a regular open fracture. And we try to simplify things, standardize the processes, have the right people at the right place. And even though when you see this picture on the right, it's been managed optimally in a center of excellence, had a fixation in one stage, had a free flap in one stage, and still this crushing component declared 2 weeks down the line. And what we do is to really restore each individual to the previous ambulatory function. If someone walked with a stick, we will try and aim towards that. If someone was an athlete, we have to give him the right to continue what he was doing. Always, I think about this phrase. This is probably 40 years ago, a publication that within the discussion of that paper said, saving a limb may ruin a life. And I always have that in mind because by nature, my specialty relies more to reconstructive limbs, try to go to the edges of reconstruction and try to give someone their limb back. But sometimes there are edges to that, which even a successful reconstruction puts the patient through years and years of pain, perhaps a late amputation. Lots of questions in my mind whenever I think that. So what's best, to amputate or reconstruct? For who? Young person versus old person? Is the limb scoring something that can predict and give to the patient some numbers? These days with AI, we can do that more predictably and speak to patients with more specific numbers. And I think the future is in that. Are the nerves, is this leg still part of the neural system that the person, when it touches the floor, can actually feel the floor? Or is this going to cause him further troubles in his later life? How much is the cost? We are lucky to be part of NHS, but in private care, this is a major input. And is the patient satisfied with the decisions? Obviously, someone wouldn't know in the first instance, but it is important when we ask for a decision making, we all, as part of an MDT, understand also the perspective of the patient. And I'll show you some numbers. This is the numbers of fractures over 5 years in the East London region. You can see the age groups, and there is 2 spikes, one around middle-aged men and one around, let's say, 60 to 80 females. And these are 2 different types of fractures. So when a surgeon has to manage a young person with the same exact injury as an old female lady that fell from the stairs, are actually 2 different things. And that's why it's so difficult to predict what's going to happen to each one. A bit busy slide here. I just want you to understand that these fractures, we don't choose when they do come, and they are periodic. So we as healthcare professionals and you as case managers, we have to be available all the time, because you would never know when these numbers will go up and they would, the healthcare system will need our input at that specific period. And I put this slide for you to understand, the more complex the fracture is, the more to the right of this curve it is, the more operation is committed to have. And this is not a choice. This is just because of the complexity of injuries that happens within the anatomy of this leg. And we think about it in a full assessment, not just for the injury, not just for the facility, the patient, their needs, where they were living before. Is it someone that neglected themselves? All these things have to come in mind for even a simple surgical decision of doing a repair of a nerve versus an amputation and not repair of a nerve. So this is something which is always, I always learn by doing the next case from the patients, from my colleagues, from my physiotherapist, etc. And we all have this great attention, and this is what's coming into lower limb trauma. The GIRF principle, it's a concept in NHS where we try to do what we know works best in the first instance. And I always have in mind this, the quality of life, everyone almost understands it, but the disability adjusted year life is something in lower extremity that is very prominent. So by just having an early decision of an amputation, the disability exists and is 100% of a loss of a leg, but the quality of life of this patient, the revisits to hospital, the infections, the uncertainty of a leg may disappear. So this is really not a choice, but it's something that we need to optimize and predict from the first instance. And we as surgeons and healthcare providers, we can advise the patients what is the most likely, reliable, and predictable route for them, not just to get a good final quality of life, but the route to that. And these are the major complex physical complications we get. Osteomyelitis, infection, something deep, which maybe involves the bone, or maybe stop the bone of healing, which is a very common presentation that me and Nima get in our practice. So we get someone who has a small open wound, and the small open wound is just the tip of an iceberg, that a patient has no healing bone, all the metal will have to be removed, and we have to redo the whole surgery from the start at 2 years after the injury. And these are some examples. So this case is an open fracture. We've managed it with the optimal way we know. We put a rod in the center, and we use some tissue from the thigh as a transplant to reconstruct this. This patient unfortunately had an infection of this metalwork, which we had to redo at least 2 more surgeries to remove this metal, put another external fixator on it, and this patient ended up with double the amount of operations that he would need. But we can't really predict that. It happens. This is another case, similar, that we use the donor side from the lateral aspect of the torso of a patient. And this patient, on top of having a loss of soft tissue, had also a loss of a segment of bone. And that automatically commits this patient to stay under Nima or another orthopedic surgeon for at least 2 years of having this frame on their leg to move this bone to meet the other side. And this is something that the patient needs to understand from the beginning. And very important, as this is happening, which is the way to save this leg, all the nerves next to this bone are also stretched and give all the rest of the sequela that we discussed, and Nima clearly said about disconfortness and disability to the other structures around the important structure, which is obviously at this stage the bone. So the next is something that I always think about. What is pain is something that is very subjective, but we as surgeons, we want to objectify it so we can help the patients. And this pain could be described as discomfort, inability to walk, cannot wear certain types of shoes, etc., etc. And you see on this slide pains that may come from degeneration of joints or chronic pain because of the actual injury. And you see a statistic under there which says 60% of these patients will have 10 years of pain of what they feel, which we do not really objectify. And persistent limb stiffness and contractures, it's all relied to the initial steps, as I said earlier, the type of injury, what was it, how was it managed initially. And nowadays, we classify the chronic pain into several aspects. And the worst one is something called the CRPS, which is relied and comes from the innate nerves that have been injured before. And this is what an early referral will save the patient for a lot of symptomatic pharmacological treatment that may not be the actual problem. So someone on very high opioids for a very long time without having a surgical consultation, which may find a neuroma that we can clearly remove and remove the source of its pain, and therefore the medications will not be required. Another case of large degloving, which we have known from the start that one of the cutaneous nerves was injured just because of the anatomy where it was. And we had to see the patient almost 6 months to 8 months down the line and try to optimize his medications. However, a simple procedure would solve this problem earlier on, or even if we knew that this could have happened, we could predict this and remodel the way of reconstruction to cover this nerve stump. Secondary health problems. Already Nima touched on that. People have pain because of the way they walk. If they walked with a frame for 2 years, if they have less activity than what they used to do, they start to be obese and their cardiovascular system has an impact as well. Mentally and psychologically, this is a very high burden for this type of injuries. Patients always, during the process of reconstruction and during the process of thinking about amputation, there is a post-traumatic disorder which makes the patient be in depression or need a lot of support. And this is where the MDT is very important, to recognize the need for this patient earlier on, rather than find that out at the later stage. Important to get those patients not just physically back to normal, but also be part of the active society. And you can see some numbers here that 50% of these patients do not return to the work within 2 years from injury, and they don't really participate socially until they pass through this process either of the reconstruction or accept and lose their limb via an amputation. This is an example of a non-physical impact following the injury. You have a crushed foot from I think it was a dustbin. We've reconstructed it with a very conspicuous good donor side free flap, but the patient is unhappy because she cannot wear her favorite shoes. And we have to do a certain other type of procedures such as flap thinning to improve this, so the patient expectations have been met, even though they're not physically causing her any pain or anything. And this is a very severe case that bridges the kind of edge of, do we reconstruct or do we not? And this is a successful story. And the reason I put it there is because we had lengthy discussions for this case to show that we can reconstruct, but we have to have the limits not to ruin someone's life. And you can see here a physiotherapist that went through 6 surgeries over, let's say, 2-3 months within the hospital and recovered greatly, and is someone that is within the system, is a physiotherapist. And I put this out there just to say we have to be aware not to reconstruct limbs that we worry that we may cause further trouble for life, but certain things are still in question. And lastly, I would like to touch also about the decision, when do we amputate, when do we reconstruct? There are certain studies. There is a New England Journal of Medicine study, the LEAP study, which published and explained that there are certain predictable parameters, such as if we reconstruct, we know the patient will be in and out of the hospital. We know that it relies on having further infections. And we do know that if we remove someone's limb, it's a shorter hospitalization. However, it has a bigger burden to his life. Therefore, the host, the person that will receive this, is very important to understand that, and we have a profile for them to give them the right advice. So what do? We think about all these parameters. This is meta-analysis studies that give us more numbers and more objective measures to what we think is the truth. And we put them all together and we try to optimize even on cases that we cannot reconstruct. And for example, this case is a case that we couldn't reconstruct, but we utilize some part of the distal foot to give a better functional stump to this lady. And you can see here the heel, the posterior aspect of the foot being part of the stump to give a better reconstructive padding for the prosthetics to be put on. And another case here, a chronic case that we have utilized the bone to lower the level of amputation for this gentleman, that he was offered an above knee amputation. However, by utilizing our knowledge, the expertise of both orthopedics and plastic surgeons, we have lowered the level of amputations for him to a below knee amputation by utilizing the distal part of the bone to give him a stump that he could actually wear prosthetics and biomechanically walk on it. That's him. So in summary, there is a lot of depth in this subject, and I always truly think that the bigger the team, the better, and each part of this team learns from the other. Important to never forget that the patient is in the center. If they feel pain, we have to listen to them. If they need structured or more long-term physiotherapy, we have to offer that to them. And we should never forget their system, their body. If their body is out of program, if they are obese, they will not be walking normally. So we have to think to incorporate also the metabolic optimization of these patients. And we all understood from these two lectures that lower extremity trauma is life-altering event, and it needs proactive and multimodal care to improve the long-term quality of life for these patients. This is my email. Thank you for your attention.
Lovely. Thank you very much, both of you, for a very interesting and informative session there. I really appreciate it. I'm sure other people do too. Q&A time, everybody. So I see we have got one question in there straight away, which is great. And I think a couple in one, actually. So I'm going to read that out. If anyone has any other further questions, please feel free to throw them in there as well. So first question for you both is, would you recommend inclusion of a rehabilitation medicine consultant for some patients? And if so, what signs and symptoms should we be looking out for as case managers to trigger requesting funds to a rehab consultant?
I think that's a great question. There is a lot to be said for inclusion of rehab consultants. They have a very interesting point of view in rehab. Now, the question always is, why is there a plateau in rehab? Why is it that the patient has stopped improving? Is it a mechanical problem? Is it a problem that will lend itself to surgical correction when the patient can then move forward? I think a rehabilitation, anytime that you think there is either a cessation in the progress of the patient or there is a change in the patient's symptoms, someone needs to look at the patient. Depending on the expertise of the rehab consultant and whether they are, because there are slightly different groups. So, for example, some look after strokes, some look after neurological issues, some look after patients with neurotrauma, and then there are a different group which may have a greater interest in limb trauma and so on. So I think as long as you get the right clinician to assess the patient, to identify the cause of the problem, that's what needs to be done. And the timing, again, it's any time that you think you've reached a point where the decision needs to be made, where there is a fork in the road, then I think that's quite important. I don't know, Gio, what do you think about that? What are your thoughts on rehab consultants?
In the question, I think they also pointed out what signs or symptoms would they be looking for to do that referral. So I would say anybody that has a pain out of proportion, and that it's probably assessed by a pain specialist, which is already part of the team, or anybody that has a wound that is unexplainably chronic, something that it has been addressed by the right clinic in that area, and it has been assessed by a medical doctor that understands wound healing, ideally a plastic surgeon. Anything that is out of proportion, I think, is important. So pain, wounds, and obviously an orthopedics sign would be a bone that it kind of fractured in an area that is already been healed or has several procedures and is unexplainable. These kind of things are the key signs, I would say.
Okay, thank you very much. That answers that question. I can't see any more questions in there at the moment. If anyone has any, we'll give you a few minutes to be able to do that. Obviously, thank you very much. Thank you. I do have a question which has come up. What is the optimum time for a physio or rehab specialist or a case manager to seek a surgical opinion?
I think again, that's a really good question. It's about when there is a question around, have we reached the end of the road with a particular rehabilitation strategy? That's one in patients who have preserved their limbs, and in patients who have amputations, as soon as there are any problems with the amputation stop. Because unfortunately, if there is an issue with the amputation stop, what you then find is that the patient will not wear their prosthetic, and by not wearing the prosthetic, the shape of the stump will continue to evolve and change, and then they become unable to wear that amputation prosthetic. So I think the access to information allows you to make decisions. So I think an early referral, I'm very much more in favor of an early referral, because then it allows you to have information which you can then base your decisions on.
Okay, thank you very much. Has anybody got any other questions? Oh, hang on, we've had one come through. For a complex client who requires multiple surgeons to be present to do a reconstructive surgery, plastics and ortho, etc., is there a place for these clients privately, or are they reliant on these surgeries on the NHS?
Well, look, that's actually the very reason that Gio and I are here today. This is not very common in the private sector, exactly as you have identified. It requires a huge amount of effort on the side of the clinicians to be able to organize this in the private sector. And that is what Gio and I do. In fact, on a Friday morning, we have combined clinics where we see and assess these patients together. I have a similar thing with a vascular colleague where we look at the patients who have peripheral vascular disease, particularly with diabetes, again, in a combined setting. So Gio and I can provide that service. We do provide that service at the London Clinic in Marylebone. And we see the patients together. We set aside an hour. So we tell our case management colleagues that, look, we need an hour. We spend the time. We provide very clear reports. Sometimes we don't have all of the information that we need. We don't have all of the investigations that we need. So we are very clear with exactly what investigations are required. That allows the case managers to then go back to their legal teams and be able to provide funding for these very specific things. And then, obviously, we need to see the patients again with the results of all of these investigations to then be able to provide a very clear strategy on how we can help these patients.
Okay, thank you very much for that. Another question has popped through. I have a couple of clients 18 months plus post-injury, tib, fib and foot fractures with ongoing numbness, swelling, vascular changes. Would there be an indication for seeking vascular consult or nerve conduction studies, or would more of a chronic symptom management approach be better?
So, again, it goes back, you need to have a diagnosis. And if you have a vascular surgeon who has a particular interest in this group of patients, it is very reasonable to see them. In fact, many of the vascular problems, particularly as it becomes more and more distal towards the foot and ankle, are much better assessed by a plastic surgeon like Mr. Pafitanis, because their interest, vascular surgeons tend to be much more interested in the bigger vessels, more proximal, in the abdomen, in the pelvis, in the thigh, even up to the knee. As you go further away from the knee towards the foot and ankle, then actually the assessment of the lymphatics and the assessment of the small vessels of the limb are much better carried out by a plastic surgeon who has an interest in limb reconstruction. Again, much the same way that there are orthopedic surgeons with an interest in reconstruction of the lower limb and shoulder and so on. There are plastic surgeons with a particular interest in the reconstruction of the limb. And Mr. Pafitanis is in fact one of those. So for this particular patient that you have mentioned here, I think I would suggest CGO. So then he can provide a plan, because we do need to assess the nerves, we need to assess the vasculature, we need to assess the lymphatics. and then to come back and see what is going on. As part of that, you may also have osteomyelitis and degenerative changes in the joints underneath the soft tissue envelope that are contributing to the symptom complex.
Yeah,
Do you want to say something about that, actually?
To add on that, it's pretty common referral this, and most times I do receive patients, or we received patients from the vascular consultants that they got the referral, but their focus of practice is more on the, let's say, above knee vessels and vasculature. And we simply advised patients, maybe we had, I remember on top of my head, a case that just was a transient post-traumatic lymphedema that eventually resolved by itself by giving the patients advice, massage, compressions. So there are things that could be solved by a simple adjustment, or may lead to what Nima said, may need further surgeries, etc.
Okay, thank you both for that. Next question is, could the costs attached to the combined clinic be shared with attendees, please?
Absolutely. So look, their consultations, usually about an hour, would probably be around £1,000 to £1,100 for the time that you have both with me and Mr. Pafitanis. The cost of that, again, you'd have to get in touch with the office. You can always contact the email. It depends, because if we've got a lot of good quality information and we need a shorter consultation, then that cost can be mitigated. But with the longer consultations, it's usually between £500 to £650 per surgeon for that individual in the consultation.
Okay, thank you very much. Another question here. So a little bit of a scenario to go with it. I don't know if you can see that, Nima, and yeah, Georgios as well.
Maybe if I read it. Client, really relevant here, injury in 2023, non-union, had the case last 3 months, reports moderate to severe pain, and the NHS consultant reports that he's comfortable. Really distressing for the client. So look, this is a really common scenario. The thing that I would say is there are many reasons for the non-union. It could be a mechanical reason, it could be a biological reason, it could be because the soft tissue envelope is not robust. That non-union needs to be investigated. That can absolutely be a cause for the pain. And if you've got a non-union which is not addressed and is associated with implants, these implants can undergo failure over time. And if you've got a broken implant, non-union and pain, that is a much more difficult problem to address. So the best way is to, again, it requires an assessment. It requires an assessment.
Okay, thank you for that. Thank you for that. I think there was some request for. You've got that on the bottom. Lovely. Thank you very much. Put that in there.
It's a very easy address. Is nh@os.clinic, and for Mr. Pafitanis, it is info@drpafitanis.com. We really, I mean, we work together as a matter of routine. So if you can refer to either of us and we assess the patient, and if required, we will then arrange for their combined review. Okay. My secretary, Nikki, and Geo's secretary, Julia, are very helpful. They're very happy to engage with the request. The other thing is that we regularly get requests for how much does it cost for a surgical procedure. And what has happened is that the case managers have received a report which says this patient requires X, Y, and Z as a surgical procedure. My answer is always, look, we have to assess the patient, because what we find, the individual surgeons that provide the opinions from the medical legal point of view, many of them are really excellent and their opinions are really valid and they have a genuine interest in that area. But also there are those who may not have such up-to-date information and such interest. So always, the response is always, look, we need access to the information. I need to see the patient. I need to address the issue, because surgery is not just a mechanical engagement between a surgeon and the patient. Managing the patient expectations, detailing to the patients what to expect and how things will be done are as important as the surgery itself.
Thank you very, very much, both of you. I think that was a very insightful and interesting and very helpful session today. So thank you both very much for your time and sharing of your knowledge and information. I think a couple of people have put brilliant and thank you in the chat, so it's really lovely. If there is no other questions at the moment, then we will end the webinar. So thank you very much, both of you.
Thank you very much. And again, thank you to you, Rachel and Hayley, for facilitating this. We're very grateful.
No problem. It's lovely to meet you. So thank you very much, and we'll see you soon. Bye.
All the best.
Thank you.
Bye.